us a little bit about the trial that you'll be presenting here at ASCO GU, including the primary endpoints and what you've seen so far?
Yes, so I'm going to be presenting the interim results of RETAIN-2, which is a phase 2 single-arm clinical trial which involves patients with clinical T2 to T3 muscle-invasive bladder cancer. Patients will be receiving neoadjuvant dose-dense MVAC plus nivolumab for 3 cycles. And in this clinical trial, we also test for a biomarker specifically that has been shown to have response to chemotherapy. So while patients are receiving neoadjuvant treatment, we send their tumor tissue for molecular testing. After completing neoadjuvant treatment, depending upon whether a patient has mutation and whether or not they have a complete clinical response, which is defined based on cystoscopic biopsies, CT scan, and urine cytology, patients are allocated to either receiving active surveillance, which essentially involves a monitoring of their bladder periodically with cystoscopies and imaging, and or if a patient does not have one of the mutations or has residual disease in their bladder, then they go on to being allocated to intervention, which could involve cystectomy or chemoradiation or intravesical therapy, depending on the amount of disease that a patient has remaining in the bladder, and based on patient-physician preference. RETAIN-2 obviously is a sequela of RETAIN-1. In this clinical RETAIN-1, which is now currently published, in this trial, patients had received neoadjuvant dose-dense MVAC, whereas in RETAIN-2, we are adding immunotherapy. The primary endpoint of this study is 2-year metastases-free survival for all patients entering the study, and that data is not yet mature. But today I'll be able to share some of the interim results in terms of metastases-free survival, as well as PT0 rates, which are quite striking with this combination.
Okay, very good. And so, as you mentioned, this trial builds upon the RETAIN-1 trial, adding immunotherapy. What were the molecular markers you looked at in terms of stratifying? Or was that used to decide whether patients would go on active surveillance or not, or was that just kind of an exploratory thing you're also looking at to see if that can predict whether they can go on active surveillance or not?
So it was an integral biomarker of this study, and we looked at mutations in ATM, RB1, and ERCC2 to decide if a patient had one of the mutations to be able to allocate to active surveillance arm.
What led you to select those biomarkers specifically?
So these biomarkers have been around for quite some time. Actually, even RETAIN-1 had these biomarkers built in them. They have previously been shown to and validated to correlate with response to chemotherapy. As the study has gone on, we have found that these may not be the best biomarkers to select for patients going on to active surveillance, as several patients who did not have the biomarker also ended up having PT0 in the cystectomy arm. And so in the future, we will probably be getting rid of this biomarker, and we'll be looking for other additional biomarkers which may be more sensitive in helping us decide who can potentially keep their bladder intact.
And so just to clarify, those who had one of the mutations and a clinical complete response were allowed to go on to active surveillance, correct?
That's correct.
Okay. But if they had a clinical complete response but did not have the mutation, then they still had to get cystectomy.
That's correct.
Okay. All right. And I wanted to, so I saw the median follow-up was about 18 and a half months.
Actually, now in the data that we'll be presenting, it is 21.7 months.
Very good. Okay. Yeah. So are you able to give us updates about the metastasis-free survival at that follow-up endpoint, and then what the PT0 rate was, and then in both groups?
Yep. So in the cystectomy, among the patients who had cystectomy, the YPT0 rate was 40%. And this number, in our opinion, is quite high and striking, despite 40% being the rate, the PAT-CR rate that we're used to hearing from before. And that's because this is the YPT0 rate, and select patients who are potentially bad players and did not get offered active surveillance. And despite this being a high-risk patient population, we're still seeing a high PAT-CR rate of 40%. This number was 15% in RETAIN-1 for comparison. Also, we're going to be reporting the YPT0 plus clinical CR rate, which is essentially combining the clinical CR rate and PAT-CR rate of patients who underwent active surveillance versus cystectomy. So basically, if you combine it for all patients who went on to the study, it comes up to 54%, which essentially could be considered as the PAT-CR rate of this combination of nivolumab and dose-dense MVAC if all patients had undergone cystectomy. And so this number is still is much higher than what we have seen with other immunotherapy, chemotherapy combinations. So based on this, we do think that it could be related to dose-dense MVAC and its immunogenic properties, that its combination with immune checkpoint inhibitor has shown us to have good results. The metastases, the 2-year metastasis-free survival is not yet mature, but based on the patients that are currently on the study, the percentage of patients who underwent intervention, 84% are metastases-free. And among the patients who went on to active surveillance, 82% are metastases-free. And 60% of the patients have, in the active surveillance arm, have an intact bladder and unradiated bladder.
Okay. And what was the local recurrence rate? So something that is a big problem or big issue that we encounter with these bladder-sparing trials. So both here, RETAIN, and then also the Hoosier group trial that was led by Dr. Galsky, is there's a lot of local recurrences now, or a good amount of local recurrences. So what was the local recurrence rate and how did those patients do?
Yep. So the local recurrence rate in RETAIN-2 was 36% in the patients going on to active surveillance. This number is lower than RETAIN-1, but this may change with more follow-up. This number is actually very similar to what was reported in Dr. Galsky's previous study as well, although that study did have a longer follow-up. And so we do feel like having a maintenance immunotherapy component in the patients who go on to receiving active surveillance may potentially be of value in the future.
Yeah, so that's the other difference between the Hoosier trial is that those who did have a clinical response and did not undergo cystectomy, they actually received an additional 4 cycles of nivolumab in the kind of like a maintenance setting, but that's not the case in RETAIN-2, correct?
Correct.
Okay. So the question is, is there a role for that maintenance immunotherapy or that, synergistic combination in the neoadjuvant setting that's allowing people to remain either if they get local recurrence, if that's still preventing distant metastases in the future, and obviously we'll need to await follow-up data to determine that, see if there are any differences in that scenario. The other thing is looking at what biomarkers are best predictors for those patients who can go on surveillance or bladder-sparing therapies. Molecular predictors, that's still in flux, whereas, other predictors such as MRI, cystoscopies, urine cytology, et cetera, seem to have been more fruitful in terms of predicting metastasis-free survival and then also PCR rate in those who do undergo cystectomies. So exciting time. So, a lot of patients do want to spare their bladder. We want to be very careful about selecting the most appropriate patients. So very important trials. So congratulations on your presentation. We look forward to hearing the data.